see if we can get it started again. The challenges of pre-hospital blood transfusion. So we've alluded to this, but very quickly, there's a growing body of literature that would suggest that harm is associated with pre-hospital IV placement. And in no subset of trauma patients is there any survival advantage to IV fluid administration. Once we get to the emergency center, volume replacement of greater than 1.5 liters was an independent risk factor of mortality moving to our damage control resuscitation for the sickest of patients. It's not an old idea. You probably all read Bickle's paper and Maddox from Houston about scooping and run and not giving any IV fluids. So, pre-trauma center red blood cell transfusion associated with reduced mortality and reduced rates of coagulopathy on presentation in severely injured patients with trauma. Lower risk of 24-hour mortality, 30-day mortality, and trauma-induced coagulopathy in the severely injured. So clearly a reason to move the damage control resuscitation to the point of injury and not wait till you bring them to see me at the emergency center. Damage control resuscitation directly addresses that early coagulopathy of trauma. I have this slide on the last one as well. The diagnosis and treatment of the entire lethal triad, and we have to bring this life-saving treatment to the patient, and the patient is not always at the hospital. So the biggest group that's done most of this in the United States is the Mayo Clinic. Don Jenkins was actually my commander when I was in Iraq. He has moved to what he is calling remote damage control resuscitation, as they're a very rural state north of me. And there are a few problems that came with that. We think of the universal plasma donors, the group AB plasma. If you look at the white population in the United States, only 4% is group AB, which creates a rather large supply and demand problem for universal donor plasma. The American Red Cross underwent a transfusion-related acute lung injury mitigation strategy, moving to predominantly male plasma, which reduced the trolley rates from 18.6 to 4.2 cases per million between 2008 and 2011, and has made a conscious decision that we will now use group A plasma. It's predominantly a male product. It has decreased trolley risk. There is a small risk of hemolysis with blood groups B and AB, but that risk is theoretical and small, and with this supply and demand problem, that has been the solution that has been undertaken. If you look at the Mayo Clinic pre-hospital plasma resuscitation, if you have a single reading of less than 90 millimeters of mercury, have a heart rate of greater than 120, a penetrating mechanism, point of care testing with a lactate greater than 5, or point of care INR greater than 1.5, any two of those 5, the order of transfusion will be 2 units of thawed plasma, A positive or A negative, followed by up to 4 units of packed red blood cells. They've done so with good safety results, no transfusion problems, but no, as of yet, in the randomized groups, demonstrated survival benefit. In Denver, have looked at the cost, do it a little bit differently, keeping things cool in a different manner in the Denver group. But you've got $1,500 for your power connection and your power inverter and your lithium-ion battery and your water bath and your control panel and your high-grade cooler. And when you start thinking about the number of ambulances and the number of units required and the logistics behind pulling this off, it is significant. The Israelis have gotten smart. We haven't gotten smart in the U.S. yet. Alon has put together this program of utilizing freeze-dried plasma. Their protocol is following what Dr. Coakley spoke of earlier today, based on radial pulses. No radial pulse, you get 1 unit of freeze-dried plasma, monitor the casualty. If there's another unit available and you still have signs of hemodynamic compromise, meaning no radial pulse, give another. The French have a product, it's military only. It's got a shelf life of a couple of years, which is fantastic. It's universal donor, it's pH buffered. No adverse effects in 8 years. I believe it's about $800 a unit. German has it as well. It's single donor, it's type specific. It's got a shorter shelf life, but still very long. It's very alkaline and must be reconstituted, and it's cheaper. In the US, there are 3 companies that are close. We anticipate an FDA-approved dried plasma product in 2015. I think we have to think beyond Afghanistan since we're pulling out, and especially for SOF and other early entry forces in the next conflict, and the application to civilian trauma care. It is believed, and one of the big surgical hypotheses is that more rapid and durable clot formation, fewer packed cell infusions, less frequent use of cryo, more ventilator-free hospital days compared with those to standard crystalloid if we move to a plasma-based resuscitation. And it's kind of a back to the future. It's not our grandfather's field plasma, but it's pretty close. Some other adjuncts. When we look at the use of prothrombin complex concentrate versus plasma and the reversal of coagulopathy and trauma, there is clearly benefit. Whether they are using warfarin or not, I think every farmer in central Missouri is on warfarin. It seems to be something we do routinely. But whether you do it alone or in conjunction with fresh frozen plasma, prothrombin complex concentrate appears to benefit the injured patient. And I think it's logistically easier to bring to the point of wounding. As we've talked before, the Matters trial, the British soldiers brought the Bastion, which drove Tactical Combat Care Committee moving to the use of tranexamic acid for American forces, and which has now taken off within the United States, is another opportunity to deliver in the field. When we look at the civilian crash tube data, clearly some benefit, whether it's within an hour you see the greatest benefits, or within the first 3 hours you still see significant benefit. We know that mortality following injury and the impact of trauma-induced coagulopathy and IV fluids is significant, with it being significantly bad for the patient. When we had brain injury, we had a whole new group of patients that have problems. So we must live up to the challenge, right? Salt solutions are of limited benefit and may actually be detrimental. We need to improve outcomes for the injured, reduce blood product usage, earlier correction of trauma-induced coagulopathy, acceptable patient profiles, and bring packed cells, plasma, and the adjuncts to point of injury care. So there are significant regulatory, and as I tried to look, it varies from country to region to state to, I'm guessing, county within Ireland. The cost is really driven by which plasma and what method you're going to use, whether it's the Mayo Clinic method of keeping it cool or whether it's keeping it frozen and warming it, as they showed in Denver with how to re-outfit an ambulance to thaw plasma. You have to modify equipment. You really have to modify about 60 plus years of medical dogma. Have to work collaboratively, as you pointed out before, with your blood bank, your pathologist, your hematologist to make this happen, and it clearly needs more research to achieve the goal, but that research is ongoing worldwide. And once again, I'd like to thank my friends who were very nice at providing slides when you're coming to give a talk. Thank you much.
Thanks, Steve.